Hello and welcome to another edition of Health in the Heartland, a program dedicated to the health issues that affect you. I'm Karen Blakelock, and the focus this episode is urology concerns. And my guests are Dr. Allison Cardin, Dr. Jason Reynolds, and Dr. Niall Harty, and they are urologists. So today we're going to really be focusing on the different things that you guys actually see in your practice. So tell us a little bit about what a urologist sees. What is the common type of patient that you see?
We see all types of urological issues involving the urinary system, so involving the kidneys, the bladder, voiding dysfunction, so problems urinating, kidney stones, and then all types of cancer, prostate cancer, bladder cancer, kidney cancer, testicular cancer, any cancer involving the urinary system or the male genital system.
Well, Dr. Cardin, you talked about voiding, and we hear a lot in the media right now on overactive bladder. So why is there so much attention? We know, I guess millions of Americans actually are suffering from overactive bladder. What's the definition of overactive bladder?
So overactive bladder is a huge problem. It's an extremely common condition that affects both men and women, although women are affected a little more often, but it certainly affects men as well and can affect any age. So I see patients in the office who are in their teens up through 80, 90-year-olds who are dealing with it. And it can really start at any point. What it is overactive bladder is sort of a large umbrella that covers urgency, so going to the bathroom where you feel like you have to go and you're not going to be able to get there in time. We call that urgency. Frequency, where you have to go to the bathroom more often than you have in the past or too frequently. And those are the two main sort of symptoms of overactive bladder. And again, it can affects millions of people. You're absolutely right, and I see people in the office every single day who are dealing with it.
Well, you said it affects all ages. Males and females. It sounds like it can be very disruptive to your daily activities, but people may not seek attention. They might be embarrassed.
Sometimes, yes, sometimes. And that's the thing about overactive bladder, and what I tell patients when I see them is often the overactive bladder, if that's all it truly is not going to affect your health. So if you didn't treat it, it might not necessarily hurt you. However, it is a huge lifestyle issue, and that's what really drives our treatment, is how is it affecting your life and what can we do to make those symptoms better. And there are excellent treatments for overactive bladder, and we certainly can make a difference in terms of the symptoms. And there are lots of different treatments. We have lots of options, and people shouldn't be embarrassed to come in and talk about it, because again, it is a problem that affects
quality of life.
Quality of life, and it affects tons of people. It's an extremely common problem.
So talk to your physician, your healthcare provider, about maybe what's going on, if they're having that urgency, the frequency that you said too, and is there incontinence also involved?
There certainly can be. If it often goes along with that urgency component, where again, you feel like you have to go to the bathroom, and sometimes if you don't get to the bathroom in time, you can have some incontinence, and that often that's the trigger for people to come in. So they've sort of been dealing with the symptoms all along, but when it gets to the point where now they're leaking urine, and they may be in the middle of Walmart and have an accident where they can't get to the bathroom in time, and sometimes that is what prompts them to come in, but we can treat it much sooner than that before it gets to that point. But yes, there can certainly be incontinence with it.
When you're saying also when that person's presenting, then obviously during the diagnosis process you're ruling out other things that might lead to some similar symptoms, because sometimes a person can present and you want to make sure it's not something else going on too.
Sure. There can be irritants in the bladder, so sometimes if you have a bladder tumor, you can have symptoms like that. Certainly if you have difficulty emptying your bladder. So for some people, the symptoms are actually that they're just not emptying their bladder well. So they may feel like they're going to the bathroom all the time, and that they don't have a problem going, but really they're not emptying well, and that's why they're having those symptoms. So that's one of the things that we rule out when we first see a patient. An enlarged prostate can do that. So in men, we want to make sure that their symptoms aren't due to not emptying well because of an enlarged prostate. And also we'll check for blood in the urine to make sure that there's no risk factors for any bladder cancer or anything like that.
Well, urinary tract infections are also common too.
Yes.
Correct? And,
yes.
and those can affect
yes,
both
and often,
genders.
Yes, and often those symptoms, you'll have those symptoms when you have a urinary tract infection. So if they go away when the infection is treated, then they were due to the infection. And if they're not bothering you at other times, then that's probably not an issue. And oftentimes, if you're having those symptoms already and then you have a urinary tract infection, it's going to make those symptoms worse. But yes, looking at their urine sample when they come into the office is one of the things that we do to rule out an infection as a cause of the symptoms.
As far as signs and symptoms, maybe in differentiating between an overactive bladder and a urinary tract infection, they might have that urgency, the frequency. I don't know about the incontinence part of it, but is burning one of those distinctive?
It can be, although, and it certainly is more common in younger patients. Most younger patients who have a urinary tract infection, although not all of them, but most of them will have some burning or irritation, pain when they're urinating, when they have an infection. But it's extremely common for older women to not have those symptoms. So oftentimes they'll have an infection and not have any symptoms at all, or just have some increased frequency and urgency. And it's really common actually to see women who don't have the burning with an infection.
So they need to seek medical attention if they're having any of those signs or symptoms to really see what's going on and make sure that they can get treated for either one. Well, we've been talking about urinary tract infections. Let's move into a little bit of the kidneys with kidney stones. So, Dr. Reynolds, tell us a little bit about kidney stones, what maybe happens, what type of individuals get kidney stones.
Well, usually there's hereditary and environmental factors that kind of weigh into kidney stones. A lot of people, if they don't get kidney stones, they can eat whatever they want their whole life, and they just won't get kidney stones. And a lot of people that get kidney stones, so there's a lot of hereditary that kind of rule into it. Some people have to deal with kidney stones their whole life, and it's just the way they're made and their genetics, you know. So as far as
now, when you said hereditary, is that if my parents have had maybe kidney stones
Correct,
that I might
correct.
also then be at risk?
Correct.
So,
So it's in your genes, or it's how you're made up when you know when your parents or their grandparents had kidney stones. So it makes you more prone to having kidney stones, and you just have to. And those are people that are more prone to get them and have to kind of deal with them more in their life. Yeah.
They talk about the calcification, I guess, with the kidney stones. So is that, how would I know if I'm maybe have kidney stones? What are the signs and symptoms?
There's a wide array of symptoms that people get, but the classic symptoms are colicky flank pain. And by colic, I mean you get intermittent pain. It comes and goes, and depending on where it is in your urinary tract. So you start at the kidneys higher up in the body and all the way down to the bladder. The tube that drains the kidneys is called the ureter. So you can have a stone anywhere from up in the kidneys down to the bladder. And where it's blocking the urine system is where the pain usually is. So it's kind of raised. So if it's high up in the kidney system, you can have flank pain up higher and toward the back. If it's down lower in the kidney system, it'll radiate down to the groin. And usually, like I say, it'll come and go. You know, it'll hit you and then be gone for a while. And it can be very intense. People that have kidney stones have an awful problem sometimes. They're
like
in a lot of
over,
pain.
maybe.
They can be nausea, vomiting, and doubled over in pain, essentially. Yeah.
One side, both sides?
It's usually unilateral. I
Okay.
mean, I guess you could have bilateral kidney stones causing obstruction, but that would be very uncommon. It's usually one side.
One side, okay. So that can be an intense pain. And can people pass kidney stones? Do they need to seek attention? When would be the point that they need to call a physician?
Usually, excuse me, usually, so if they're in pain like we're talking about, they're going to seek a physician. They're going to be in the ER. But there's a whole array of things. So some people that have a lot of problems with kidney stones, they kind of know when they're having a kidney stone and they'll come on in. Especially people that, if you know you're having a problem with kidney stones and you have a fever, you need to come in and be treated for sure. That's very dangerous. And also, if the person that has just one kidney, if they're having a problem with kidney stone, they need to come in for sure. A lot of times people have abdominal pain, they don't know what it is, and when we see them in the ER, we're not sure what it is, and we have to kind of figure it out and figure out that it is a kidney stone if it's their first time and everything. So.
Kind of like if it's in your side, you don't know if it's your appendix, your kidney, what's going on. You need to seek attention to make sure you know what's going on. Now, if a person is diagnosed as having kidney stones, are there common foods that they need to stay away from? Or you mentioned something about diet.
Right. So everybody that has a kidney stone, we kind of, we'll talk to them about conservative measures that they can do to help prevent kidney stones. Number 1, 2, and 3 is probably drink more fluids. People need to drink plenty of fluids if they're known to have kidney stones and they have a lot of kidney stones. Urine output needs to be somewhere like 1.5 to 2 liters a day on people that have a real problem with kidney stones. They need to drink plenty of fluids. And water is probably the best thing they can drink. And you can put this flavored stuff in the water to help. Some people just hate drinking water, but that kind of helps some people. The second thing you can do is they've shown if you decrease your salt intake, everything in moderation is a good point just for kidney stones. As far as food intake, moderate your salt intake. You don't want to put a lot of salt on things. You want to watch your meat intake, and that's not just red meat. That's all types of meat. They've shown fish, chicken, and meat. All three can make more kidney stones. And also in recent years, now it used to be thought as far as calcium intake, you think kidney stones, you're making stones, you want to decrease your calcium, but that's been shown in the last few years not to be the case. The most common type of stone is calcium oxalate. About 90% of people, over 90%, will have calcium oxalate stones. So they've shown that you want to take in a normal amount of calcium now for kidney stone formers, and that's about, for men, I think 1,000 milligrams a day, and for women about 1,200 milligrams a day. What that does is that'll bind oxalate actually in your intestinal system, take that out so it can't bind as much calcium, make as many kidney stones. So now they've shown you want to take in a normal amount of calcium to help prevent kidney stones. So to review, it's plenty of fluids, decrease your salt intake, decrease your meat intake, and then take in a normal amount of calcium every day for common stone formers.
Sounds good. Now, are there times when if an individual is at risk, and I'm going to use a woman as an example, is she more at risk if she knows she might be at risk for kidney stones because of the genetics we've been talking about? Pregnancy, is there a higher risk for that to be a time where she might get kidney stones, or no? I'm just asking.
So in pregnancy, it's been shown that there's not an increased risk.
Okay.
The things that cause stones are increased during pregnancy, but actually the inhibitors in your body, the things that keep stones from forming, also increase. And so overall, there's not an increased risk of stones during pregnancy.
So again, as you had just mentioned, that moderation of making sure we're drinking lots of water, which we all should do anyway, right? Not just somebody that might be at risk for kidney stones. And then watch the meat intake and then the salt intake too. So just some good general tips for our diets in general. And when you really mentioned water, not just fluids, but really water, correct?
Correct.
Because I think a lot of people think soda is, and not. We need to drink water.
It's better. One of the things we talk against is tea because it has a lot of oxalate.
Okay.
And some people
Good
don't.
example.
Some people don't. Like I said, the most common stone is calcium oxalate, but some people don't form calcium oxalate. But they're kind of the exception. So usually you want to decrease you don't want to drink. Some people drink tea all day long.
We do live in a belt of sweet tea area too, so that's a good point.
So,
we appreciate you bringing that up. Well, we've been talking about overactive bladder. We've talked about kidney stones. We're going to switch now and talk a little about prostate cancer. And Dr. Harty, tell us about some of the new recommendations for guidelines for prostate cancer screening.
Sure. So prostate cancer is one of the most common cancers in males. It affects anywhere between 1 in 6 and 1 in 8 men. Risk factors would be increasing age and a family history of prostate cancer. And typically African American males have a more aggressive forms of prostate cancer. And previously, as urologists, we used to do annual screening of males for prostate cancer, and what that consisted of was a digital rectal exam where we felt the prostate and we were looking for any nodules, and that would be a concerning finding on physical exam. And we used to do a PSA, which is a blood test, to look at the value of the PSA. And there were thresholds that we used to be concerned that would maybe prompt us to go further on in the workup and do a biopsy of the prostate. Up until about 2 years ago, that was the norm, and now we've switched over based on 2 large trials, and the American Urological Association has changed the recommendations for prostate cancer screening. And primarily what I think the results showed is that we were over-treating, essentially, is that many forms of prostate cancer had low potential to actually harm or kill, and the side effects of surgery, primarily incontinence and impotence, that were being seen after treatment, and these quality of life these were quality of life issues that were affecting males who were being treated. So nowadays, It's essentially an informed decision that you have with your physician, with your urologist, that you discuss what are the risks and the benefits and alternatives to screening. So typically, the main population of men that are screened or that you discuss screening with are between ages of 55 and 69 years of age. People who have a strong family history or patients who are African American, you may consider earlier potential screening. But as of right now, the recommendations are for no routine annual screening. However, if a patient wishes to have that, we can certainly do that for the patient.
So it sounds like it's been lessened from a general population screening, as far as widespread campaigning to really make sure that, we're getting everybody in the population, but really sitting down and talking about your personal history with your healthcare provider and what is best for you.
Exactly.
And that's that informed decision you
It's
had mentioned.
become less of a routine annual screening, and it's become more of an informed decision with the patient in discussing what screening is, what we do if we find certain findings, and how we proceed from there.
Okay. And still two-part, though, if that would happen, that would be the PSA and then also the DRE
exactly.
at that point with the informed decision.
Exactly, and based on those two factors, if we, for example, found a nodule on the digital rectal exam, that would be concerning and it would prompt us to do a prostate biopsy. And if we had a very high PSA, we could look at other factors, but again, that would be certainly a concerning finding as well for a male.
I'm hearing kind of an overall theme with what we've been talking about with kidney stones and especially, prostate cancer here too. It's really a good idea to know your family history as far as your genetics and that background that does predispose you sometimes for some health concerns, but then also your lifestyle and what you're doing too. So it's kind of background and then also what am I doing day in and day out to put me at risk for some of the different things that are out there as far as our health concerns and disease processes. So you really need to keep a record and kind of keep tabs on what you do day in and day out as far as taking care of your health. We've been talking about those different health issues. What actually is new in as far as treatment overall with urology? I know robotics, was something new in the last couple of years in taking care of a lot of the surgery that is going on. Anything else going on right now with treatment with urology?
There's some newer toys or tools that we have with the robot, so that's kind of exciting.
And that really lessens the patient's stay, I guess, in the hospital generally.
Yes.
And that's why that advancement had been made in the last, was it five years, I guess I should say, or was it longer than that?
It's been a little bit longer than that. I've been doing robotics, I guess, for probably the first case I was involved in was about probably 10 years ago.
10 years
so
ago? Okay.
It's been a little while, 10 to 12 years I'd say, but it's only recently been where it's sort of widespread, where robotics are available in most hospitals.
And sometimes that's not for every patient. Again,
No, not always. There are very certain conditions that we use, the Da Vinci robot, which is what we're talking about, that we use to treat. So just very certain conditions. So not every surgery we do as urologists are we going to use the robot for. But they are definitely, it's mainly for larger surgeries, and there's no question with, particularly with kidney cancer and prostate cancer as well, that it has definitely decreased the length of stay in the hospital and has speeded recovery time.
Now, you all are with HMH surgical specialists, so we hear the word specialist. Do they need to seek attention with their primary health care provider first and then usually are referred to you all? Is that generally how that works?
Yes. And a lot of the things that we've sort of been talking about, and particularly what I talked about in the beginning, overactive bladder, often primary care doctors will treat that and will refer patients to a urologist if the first or second line of treatment isn't working. So if we've tried a couple of medicines and they haven't made a difference, or if there's some concerns for other issues that may be going on. But in general, it usually is a referral from your primary care doctor.
We've talked about the various types of cancer as far as bladder, prostate, and kidney cancer. Those individuals are definitely seeking your attention to make sure whether there's surgery interventions and different things too. We had been talking about the prostate, but we didn't mention anything about BPH. Dr. Reynolds, tell us a little bit about what is BPH and what does it stand for? Who gets it?
So we've talked all about, prostate cancer, but we also treat a lot of benign problems with the prostate. So BPH is benign prostatic hypertrophy, and that's just a long word for the cells in the prostate are growing and cause problems with urination. So it's very prevalent in older gentlemen. If you live to an older age as a man, me and Dr. Harty included, we're going to be lucky enough to have BPH probably. It's what it is, well, the prevalence essentially is like if 50% of men at 50 and then 90% of men at 90, it almost follows age as far as how it bothers you. And what it does is the prostate sits right under the bladder, and the tube that you actually urinate through goes through the prostate. So as you get older, those cells kind of enlarge and encroach or kind of come into that tube, and it makes you have trouble urinating. It's essentially what the problem is. You can't get the urine out as easily as you could when you were younger. And so as men get older, they have more problems with this. And then we have all sorts of treatments that we use depending on how bad it is to treat this. And we see a lot of this. This is very common in our practice.
So benign means no cancer is present,
No cancer.
just an enlarged prostate.
Correct.
And when I say just, that is causing uncomfortable signs and symptoms, obviously, that need to be treated through the urologist. What age bracket does that, part of the normal aging process?
It is. It's part of the normal aging process. And like I say, if you live to be 80, 80-90% of people 80 are going to have a problem with BPH or a problem with urinary symptoms from that. And one thing I see a lot that I thought would be good to just to say is a lot of men, they get urinary symptoms mixed up with prostate cancer. And today with PSA, we don't. Usually when a person comes in with prostate cancer, they don't have any symptoms at all. And I've had a lot of men come to me with urinary symptoms, frequency, urgency, problems that are caused by BPH, and they're extremely worried about prostate cancer. And I spend a lot of time counseling people that usually almost never are these two, unless prostate cancer is very advanced, are these two tied together at all. So it would be very uncommon for you to come in to me for BPH with urinary frequency, urgency, and have a problem with prostate cancer.
Another common concern, I think, especially for males, and we're hearing a lot again, immediate attention, is erectile dysfunction. Dr. Harty, what age bracket, when do they start seeing?
Sure. So erectile dysfunction can really affect any age. Typically and most commonly affect males as we age, potentially with lower testosterone levels. But it can be due to a variety of factors. Some can be post-surgical, as we talked about, after treatment, let's say, such as prostate cancer. Some people who have multiple comorbidities, such as high blood pressure, diabetics, or who have suffered some sort of pelvic injury, perhaps may have erectile dysfunction. Typically, patients would notice, obviously, an inability to sustain an erection. And what we do typically is take a thorough history and do a physical exam to look for any risk factors for erectile dysfunction. From there, we can talk about treatment options, and typically what we like to start off with is a pill form, and you may see some of those in commercials such as Viagra, Levitra, Cialis. Those are some of the common medications, and there's some new ones that have come out. And typically that's a pill form that can help with the mechanism that the body has to achieve an erection. From there, if those don't work, there's other treatment options such as injection therapy or things such as a vacuum pump that can help with an erection. And if those options don't work, we can always go on to a surgical procedure where we do what we call an implant a penile prosthesis that can help with erection. So it's a common problem. It affects men, and it affects couples in their relationships. There are treatment options out there. It's a very treatable medical problem,
right.
And so somebody should not be shy to present with that. It's a common thing that we see in our practices, so we're happy to help those patients.
Exactly. Those are things to just, again, partner with your healthcare professional and discuss what's going on, really, so that they can help treat you. Are there certain disease processes that might put you at risk for erectile dysfunction?
Yeah. Patients with such as peripheral vascular disease could have a problem. Diabetics could have a problem. Patients with high blood pressure could have a problem. So those would be the kind of three of the medical problems that, if aren't properly treated, could lead to long-term erectile dysfunction.
and I don't know, and I'm asking, I guess, for some of the things that we've talked about, sometimes is it good, I know when a patient is presenting to you, that if they have a little bit of a diary or they write down maybe what's been going on, so that when they get to the office, they're telling you this has been happening for 2 weeks now, 3 weeks now, you know, so you kind of get a timeline of the signs and symptoms, and maybe they need to bring their personal history obviously in with them too, so that they know their background, maybe the disease processes that they have, medications,
Absolutely.
different things too. So
It's rare to have too much information.
that's a good thing then, to come prepared. And I think it's also a good idea as they come to you know, speak with their healthcare provider, maybe write down some of the questions that they might want answered too, because they get into the office and you might be talking about something else and they leave and don't maybe have that one answer to that question that they might need to, right?
Definitely.
So come prepared as they come to see you. So it sounds like we've had some good advice as far as some general tips to avoid kidney stones, making sure we're drinking and drinking water, obviously, and avoiding salt and meat. And really, I think the overall theme is make sure that you talk to your healthcare professional about some of the signs and symptoms that you might be experiencing, and don't be too embarrassed to open that discussion. And then also partnering with them to have that informed decision about when it's appropriate to be screened for different things too. Well, we appreciate the important information that you've shared with us today, and hopefully some individuals will seek some attention from some signs and symptoms they might be experiencing. And for more information, we invite you to go to www.hmh.net, and we hope you tune in next month for another important edition of Health in the Heartland.